Yes, thank you for invitation to TIC. So myself, Dr. Kinney, Director of the Cath Lab, and I have Amit Huda, who is the Associate Director for our fellowship program. Dr. Sharma is in India, so we will be doing the live case here from Mount Sinai. I have Pratish George, who actually is from Vellore, who has come here for 2 years, interventional fellow, and he'll be doing structural and going back to Tamil Nadu. Hopefully in 2 years he'll be there as a faculty in your TIC. And then I have Gaurav Arora, who is also from Mumbai. Ki is going to be our imaging, who is behind us. And we have our usual team, which includes Will, Alina, Asif, Habib. So we are going to show you the first case. So nothing to disclose from our side. So this is a patient who is a 84-year-old female. She actually presented with progressive dyspnea and some heart failure symptoms early part of this month. Also had a positive dobutamine stress echo with some wall motion abnormality with the lateral apical region, which you will see in the LV-gram, you still see it. In the past, she has had cath, which has shown a non-obstructive CAD. So her EF varies between 45 to 50. So she has risk factor wise controlled hypertension, uncontrolled diabetes, hemoglobin A1C is above 8, uncontrolled lipids, and on dialysis. So her SAQ score is about 70 and definitely is frail. So if you see, we have some important numbers. Our LDL is 72, but the rest are all high. We didn't have a CRP. We usually check CRP on every patient that gets a PCI, not just gets a cath. So medication wise, you can see good medical therapy that she's on. So I will show you the angiogram where she has left main disease and syntax was about 3.8. So whenever there is comorbidities, especially diabetic, dialysis patient, left main disease, we always try to get a surgical consultation. So she was seen by surgeons, and because of her comorbidities, frailty was considered that she's high risk. So why not go for a PCI? So that's where she is today, to have a PCI of the left main. So if it's okay, I'm going to show you the, can we go to the angiogram now? So this is EDP is normal. She was dialyzed yesterday. So this is what I think a DSC showed also. You see the anterolateral wall and apex, which is hypo. We are getting EF about 45. Right coronary artery is normal. So even here you can see there is calcium in the mitral annular area, and you can appreciate the calcium in the left main and left coronaries. So this is an old way, but the way that we learned how to analyze calcium, many of the trials still use this, that a dry CNA is showing a tram track calcium here. In the left main, LAD, circumflex territory. So this is where the first injection, actually it was like about 90-95%, but almost subtotal circ now. So in the caudal view, it looks like maybe moderate left main, questionable LAD disease. But in the cranial view, looks like at least 50% left main and probably 50% LAD. So this is where we are with regards to the angiogram. So if we go back to the slides. So we always check what are the guideline wise. The guideline wise does, you have to check syntax score, you have to check STS risk, and of course the frailty index. So based on everything, if you see here, syntax of 24, diabetic syntax about 23, always consider a surgical option. STS score is okay, reasonable, but that's why the heart team discussion is done. So after heart team discussion, this kind of patient then becomes meeting the appropriate criteria. So we could start with the case now. If we can open it for discussion, we can go back to the angiogram. So what we plan to do is, because of the calcium, we plan to do rotational atherectomy from left main to circumflex, and after that we will likely do imaging and then decide what should be the stenting strategy? Left main to LAD will image, left main to circumflex will image. Do we need any further calcium modification, or will be okay just after rotational atherectomy? Now if somebody tells me why don't we just go with the other, like we have orbital atherectomy, can it be done? It can be done. It's the operator preference. Can we just go with IVL here? This kind of a lesion, probably yes. It may or may not cross. You may have to probably dilate and then cross, but our center, we would first do rotational atherectomy and then do the subsequent any other technique for calcium modification.
Dr. Kinney, can we put a wire into that and analyze by IVUS to understand that how the calcium is looking like? After that, we can take a decision of which type of atherectomy to be done, or definitely by looking at the angiogram, you require atherectomy, whether it is orbital or rotational. It depends upon our own operator choice. But we can do just an IVUS to understand that how much significant the calcium in both the sides in circ as well as LAD. Then we can plan it. Is it a wise up decision?
Yeah, excellent question. And let me tell you why that's not advisable here. I can't show you right now. Now show the hemodynamics in the side. This is what the blood pressure was, okay? And then as soon as if you see here the first picture, right, we showed. Let me go back here. So the first angio that we did is, next one. Look at the TIMI flow. It's like barely 1.5, not even 2. So in this kind of situation, I think, and after we wired, okay, because we decided we can do only one technique, after we wired, the pressure was less than 100, hovering in the 90, so we have to give some niacin to keep the blood pressure up. What I'm trying to say is, when there is this kind of a situation, when there's left main disease and the flow in one of the vessel is less, then I think avoid imaging. That's why we showed you how can you make a decision based just on angiography, that severe calcium, do first any kind of a technique of modification, then do imaging and consider if you need anything else.
Just to summarize the case for the new audience who are here, is a high-risk patient, declined surgery, who's got a 110 versus 1 query, 1 lesion, 1 query 1 and 1 lesion in the distal left main, densely calcified vessel, severe calcification, the TIMI2 flow or 1.2 less than 2 flow in circumflex, planned for rotablation with the groin is the axis, the LVEDP was fine. That was the reason I think why they didn't go for an impella. Otherwise, they might have, I am sure, Dr. Kinney, you might have considered an impella if the LVEDP was 35, 40, am I right?
Yeah, 100% EDP was high, we would consider number one. Low EF, I mean, the blood, see if the EF is about 45, 50, if somebody says, I want to keep a balloon pump, nothing wrong. Many people would say, to do this kind of a case, I would want a balloon pump, we'll say, okay, go ahead, that's the right strategy. For impella, even though the EDP is high, I think you would probably need your EF less than 40, closer to 35, 30 or so. So we have our ROta. Now, going with what kind of a wire choice, Amit would go over it, but more important, how would you select? So the question that was raised by imaging, yes, you can decide what is the calcium modification that you want to use, whether it is ROta, OA or direct IVL. I will show you the algorithm that we have created. And the second one is the size of the burr. Okay, so we saw that it's TIMI2 flow or 1.5 there. So in that situation, downsize the burr, it is circumflex. So we have selected 1.5. The reason also is that if something extra need to be done, we can always consider IVL. Amit, you want to discuss what is the wire choice here?
Yeah. Hi, thank you, Bhupti, for having us. Yeah, in the circ, because of the angulation, we tend to have a wire which will have a reduced bias. So mostly we choose a floppy wire only, because we don't need any extreme support here. It's a short lesion. And like Dr. Kinney said, we wanted to modify it appropriately, but not to with a very small burr and not to with a big burr to avoid complications. So we chose 1.5 and the floppy ROta wire only in this case. But I would like to know what panelists think, whether they have gone with the extra support or just a ROta wire floppy.
I think I would have done the same. Being from there, it's a long sheet, 7 French guide, 1.5. It's okay to undersize the burr on the circumference side, be on the safer side. I think across the lesion.
So slow pecking motion, you see that? You see my hand movements? Yes. Are you able to see that? Yes.
Rectangulation.
Yeah.
The rest of vessel is going to be mostly 3, so 1.5 burr is going to 0.5.
And you
is 0.5 to 0.6.
So you can see a little bit of EKG changes. Blood pressure is already low. Okay, so I think we have done a nice burring. We are going to come out. Get me the wires. And now we can image.
Slow steady burring is required. 1.5 is an ideal burr in this case. Probably vessel will decrease to 3.5 millimeter vessel. I don't think the circumflex is less than 3 millimeter. It will be 3.5 vessel. So the 1.75 is not a good choice, especially when you have a kidney 2 flow there, and you should have a minimum picking movement is there required, and just open the strut and then open the ostium and then see what is the imaging and what imaging shows. Probably you'll be doing an IVUS now, right?
Yep.
Yeah, see the blood pressure is low. Let's make sure the flow is okay. Yeah, good. The vessel is good. So the most important thing, I think I did listen to your complication part. Pay attention to the EKG and the hemodynamics. When there is some changes, the vessel is telling you there's something wrong, and that's the time you got to move quickly. So I will go with the fielder wire to the circumflex, and we will go with the run through. That's our workhorse wire. That's what I'm saying. So we always like 2 different kind of wire. Why we use 2 different kind of wire? Because the color is different and easier when you're doing bifurcation stenting. One is green, one is gray. So we know always the green is in the side branch.
For the sake of learning purposes, as Dr. Pratap Kumar sir clearly told, when there is a slow flow in any vessel, the higher the burr size, slower the chances for us to have a slow flow is going to be on the higher side. Higher the speed, the chances for us to going to have a slow flow is going to be on the higher side. So do not accelerate the speed and do not go with the bigger burr, especially slow flow situation is already existing.
Okay, give me the run through. It came out. So what happened is I wanted to take the ROta wire out, which we did. Okay. Then we have this wire, and then we go with the run through. Okay, give me the needle.
Dr. Gini, one of the panel moderators here, Dr. Madhavan sir, asked, why couldn't we just balloon the ostial circumflex and do imaging before going for rotablation, especially when atherectomy failed in Eclipse study?
Yeah, so that atherectomy is orbital atherectomy. So there's no direct comparison of ROta and IVL at in any studies. Okay, we have published our retrospective study where actually, okay, OA, if you understand the mechanism of OA, now RA is what? You remember the burr, the diamond chip is at the tip of the burr. OA is different, orbits around. So going back to the point that, yes, Excel trial did show for the first time there was complication compared to just the balloon angioplasty in the OA arm. So that Eclipse has done that. Now, since based on what we showed on the cine itself, the heavy calcium, right? That you go. Yeah. TIMI, there's already TIMI 1.52 flow. Now I go with the balloon. Balloon may not expand, and then may we cause the vessel to close or something happens. Then we are into some kind of a situation. Instead of that, what we do and which we always have taught, I'm going to the circ first, always have taught that if we think you're able to do ROta, then do ROta, like we said, get some flow. You saw how the flow is much better now. Now we have time, let's image it and then decide what to do.
this bell.
Now, my question is that before going for ROta, just a pass of balloon, not dilated, just a pass of balloon, whether it is easily smoothly going or not, then we can take a call whether should it be ROta or any modification should be done.
No, why I still, but mine, suppose the balloon goes. So what will you decide? How will you decide?
No, suppose the balloon goes, easily it goes,
Hmm.
then we may do imaging and see whether ROta is really needed or just NC balloon can do the job or not.
Mm.
Without imaging, straight away going with ROta ablation.
Mm.
Basically,
That is
then
why-
that's the same question I
Some
asked Madhav when I asked that you can
So-
take
you
IVUS
see that?
directly and what is it? She told
Okay,
us
check
Can
the
you see
image. Okay, can I start from here?
he did not take it.
Can I start, IVUS?
Yes, yes.
Okay, start feedback. It's coming. Proximal Turk. It's a Boston.
The point
Avigo
I'm
class.
making again, that if you see severe
Okay,
calcium on
got it.
angiography, I
Just a
think
quick
doing
feedback.
this imaging,
Yeah, you can take it out.
understanding
It's
how
a
much is
obstructive
the
lesion.
calcium there, not there, because once you get, if you get into any kind of trouble by when you're doing IVUS, doing a balloon to check,
So I will show you. So this is the left main.
then you'll have no time to recover. You have left main? Yes.
Yeah, this is the left main, and this is the distal left main.
Okay.
And you see the LED wire from the 7 o'clock and go inside. So this is the osteal circ. Yeah, you see that like a 180 degree and kind of protruding, might be calcium nodule.
You see a
And,
calcified nodule.
Yeah, but very short like calcium nodule lesion at the osteal circ. Then come to the like almost healthy landing zone,
Let's go
like
to the
a more than 4 vessel. So very short calcified nodule at the osteal circ, and also distal left main has a calcified nodule.
Actually,
that's-
there is 2 to 3 millimeters of actually the osteal circ disease and circumflex is nearly 4 millimeter vessel, correct?
Yeah, correct. Exactly. This is a proximal circ after the lesion. The IVUS said lumen is 3.7. The EEL is like 4.5 vessel. That's the
Now-
proximal circ.
The thing is, there is a nodule. The nodule is almost 2 quadrant, right?
Yep. Osteal circ very
Okay, now
focal,
I'm going
but,
to the LED.
Yep. Sounds good.
Flush it. We are in the LED. Can you see it?
Okay, check the live. Yep. It's a like eccentric calcium. Can I start from here? Okay,
Yes,
start
yes.
pullback.
Not the pullback.
Yeah, it's coming. Oh, it's also a very short one.
Hmm. Okay, hold on. Let
Yep.
me go back again.
Oh, sure.
Okay. Okay, go now.
Okay, here's also like eccentric calcium, but I saw pullback
Mm-hmm.
coming. Yeah, diffuse eccentric plaque. Yep. And got it.
Okay, so left main to LED. Show me.
Yep. So this is the mid.
Osteal LED.
Yeah, 1 second. Now
Flush
come
it
to the
and have it
proximal
ready.
LED. Area is good. Then this is the bifurcation. You see the circ branch from the 3 o'clock.
Mm.
So after that, so this is again the osteal LED. Actually, osteal LED also has, okay, this is, sometimes the AI doesn't work well because of this kind of causal lesion.
So we are using the Avigo IVUS from
Yep.
Boston Scientific, 60 megahertz, but they say there is AI analysis, but as soon as there's calcium, the analysis is not true, then we have to do, human has to interfere.
Yeah. And so,
So the osteum is deceased.
yeah, osteal disease, 1 second. So this is at the, just after the bifurcation.
Yeah. So again, you say more than 2 quadrants, calcium.
Yeah, and osteal LED area is like a little bit under like 4.
3.5.
It's like 3.5, but huge plaque burden, like a 70% plaque burden.
So what I think we should do, since there is a calcified nodule, which
Yep.
is a large, I would say, almost 2 quadrants in the circumflex, and the osteal LED is involved.
Yep.
Best thing is take an IVL. Okay. The question is, what should be the size? If you go with the vessel size, it will be 4O, right? What do you think? 1, 2, 3.
Can take an
3.5.
IVL of 3.5
Yeah.
millimeters.
So maybe we take a 3.5 IVL, do circumflex, do LED, we IVUS, and then we do the stenting. Everybody agrees?
The calcium nodule in the left distal LMC extending to the LED osteoproximal part as well as to circumflex, nearly very, very short lesion length is actually less than 2 to 3 millimeters in circumference as well as palliative. Basically, it is all the three quadrants are actually 2 quadrants calcium.
Yeah, 2 quadrants calcium. Now we have seen this, I think, in a couple of the live cases, right, Amit? And Amit also does so many, calcific lesions with Dr. Sharma here. That when the calcium, what we say is you need calcium plate around. So you can have a nodule. Like here, there's a nodule for in the 2 quadrants, but the opposite area does not have calcium. So this kind of situation we have seen, there is contained perforation that we have seen with IVL.
IVL is actually, now actually what my question is coming back. Now, if you look at this one, what is atherectomy choice? Atherectomy choice would have been much better is actually orbital than rotational atherectomy.
No. I am the only propagand who will say that when you want to do orbital atherectomy, that was the same question that was raised. Why did we see that in Eclipse trial? You need minimum 3 quadrants to 4 quadrants. What is the mechanism? Orbit. It goes round.
The same
So
thing
in that
actually
case, you need 3 to 4 quadrants of calcium.
Principle applies,
Okay, go.
Rotational atherectomy also indication
Down,
is 3 quadrants in 270-degree calcium. If it is actually 2 quadrants, you use the rotational atherectomy.
Understand, but the principle is there's deflection of the vessel which is not calcified.
Madam, that is why I told that we could have done it.
Go.
Yeah, going.
Yeah, there are always 2 different ways of doing things. Maybe this is the preferred way there. Nothing is wrong or nothing is right. There's an image study that compared rotablation versus atherectomy that showed that OA actually creates burrows, especially in creates gutters, and rotational atherectomy actually cuts.
Nodular, actually, the calcium nodule basically is a nodular calcium that is OA is little better than rotational atherectomy. Here in this case, basically IVL is definitely a better choice than both the modalities because actually it is confined to small vessel. The same both the wire can be kept there and you can take the device into both the places. Otherwise, you have to take the wire out and then one wire keeping there. And
Ready?
it is not practically possible.
Going.
I think in this case, we already made a point. The TIMI flow, look at the blood pressure, okay? Every time we are going up, there is hypotension.
I think it's also depending upon your personal choices and expertise
Go.
and experiences, what you feel more comfortable with. So
Yes.
Yeah, I agree with the earlier comment also. That is the operators, like what you are more comfortable doing it. And we totally agree, there are so many choices. But Dr. Sharma and Dr. Kinney being the pioneer in ROta ablation, we are more comfortable doing ROta up front instead of, later on thinking that we could have changed it. So that's why we are a little more pro for ROta. I would put it that way. But yeah, there are no right or wrong here.
No, their question was, he's trying to say that IVL could have been done with wiring both vessel rather than single vessel and all that. We are trying to say when the vessel has a slow flow, doing IVL, right?
Yeah.
Not even knowing that IVL would cross. In disrupt CAD, 50% of the time they have to dilate the lesion. And what if the lesion does not dilate? Calcific lesion.
And given the underlying ESRD, it's an angulated circ, very significant disease, low pressure to begin with TIMI, 2 flow kind of situation, we thought it would be safer to do upfront ROta instead of later on switching back to ROta if required. So yeah, I think that's just one way of doing things, and we agree but we didn't want to have a ROta regret later on.
Yeah, just for a theoretical purpose, Dr. Kinney, let's presume no disease in the Australian lady. How you would have posed this lesion? That is basically a 101 lesion.
Yeah, then you could probably stent across. Yeah, you could probably have stented across. Okay.
You would have stented across.
Yes.
And would you like to end up with a kiss or not?
I would not, based on our analysis of the Excel data. But,
Okay.
again, there are So many people will say they want to kiss and keep the stent side open. I want to see.
You may not.
Now IVL is not even going into the LAD since it was already used once.
So
See
in
that?
your case, you may take 1-to-1 size into the LED. You may take
Okay,
size,
now
just
let's get a 3-5 balloon.
Yeah, we have. But Bhupti, like what the panelists think, do they do routine KBI or like usually we don't perform routine KBI, except it's like there is a significant compromise of the side branch, even if it is left main. But what the panelists think, like do most of them do routine KBI or like
Give me
just
3-5 balloon.
do only when it is required?
No, we don't do routine KBI
Okay.
in this case. Basically, when you do an intervention and putting a stent across, as Kinney told, you do another IVUS to the other side, other vessel, and then take a decision. That is also another option,
Yeah.
It is not the routine KBI to be done, especially in this case. What I have seen is actually there is a 2 millimeter ostial LAD lesion is there. 2 to 3 millimeters ostial circle is there, LMCA disease is there. That is why there was a struggle of taking a once used the IVL balloon could not be taken into this LAD. Definitely because it is a 3.5 millimeter IVL. Definitely it is not easy to take. Now it is a normal balloon, normal NC balloon, I think.
Yeah, this
yeah.
is just a 3-5 non-compliant balloon.
Okay, down.
Just for the sake of audience, the subgroup analysis of Excel showed there is no difference between
Okay, go.
doing a kissing and not kissing even after two-stent strategy. Ironically, that's surprisingly, even in
Give us the
two-stent strategy,
IVUS quickly.
there was no benefit. Even after two-stent strategy, subgroup analysis of Excel.
You already saw the IVL would not go into the LAD, so we just did a high pressure balloon.
It is actually a normal because IVL is such a balloon, it's a bulky balloon to take a device down, especially it's a 3.5 IVL balloon.
But at least we were able to do atherectomy into one arm.
Yeah.
Yeah.
Now the plan is to do an IVUS to both the vessels before.
Yeah. No. I'm just going to do IVUS of the LAD if that because I do not like this consistent hypotension here.
Yeah, like
You see that? Yeah. So that's the key. That's why this kind of high risk have to be planned. We planned one way and keep going fast. Because she came in with a blood pressure of 140.
and the patient is still on neo drip in the
Yes.
background. So, and we didn't opt for
That
any
was what
support in
Bhupati's
this
question
device.
was initially.
So
But
we thought like we'll just want to be little quick in this case.
there's so much calcium even now. You see that in the mid LAD area there is calcium that is not. Can you see anything?
Yeah, this
Ostial?
is the proximal part of LAD.
Okay.
Okay, start fullback.
Yeah, start.
Coming. Yeah, quick pullback. Left main. And that's it. I will stop it.
Good.
Can take it out. Yeah. this
Did
is the pulse.
just the high pressure balloon do anything?
Okay, so this is the bifurcation because we see the circle here. So, and this is the ostial or LAD. Of course, with IVUS resolution, hard to see the fractures.
What?
But area-wise, it's bigger because it was like less than 4. Now it's 5.3. So area is expanded. And actually, ostial LAD is like 180 calcium. So it's not, we don't call severe. Because nodule is the distal left main, the ostial circ. Proximal LAD is just a 180 calcium sheet.
Hmm.
So yeah, I think it's.
But what I meant is, do you think we have, did we cause any cracks there?
So based on the IVUS resolution, I don't see the
Nothing?
dynamic fractures. But one second. So might be some internal dissection between the causal plug and the fibrous plug at the
So, okay,
9 o'clock.
okay, that's good enough.
Possible, yeah, dissection. But it means a good
Quickly
plug
give me-
modification.
Let me go to the circ. I think let's image the circ at least. If the IVL has done something there, then we can. But everybody agrees we do 2-stent strategy.
I think a two-stent strategy is a must in this case. Number one. Number two, IVL did not. There is a luminal gain in the ostial LAD, but there is no crack can be seen in that calcium part. Probably that is because a nodular calcium extending to one side. The opposite side, there definitely there is a luminal gain. It is actually increased to 5 millimeters square now.
Yep.
Okay, we are going into the circumflex quickly. You're ready? Flushed? If it goes well. Okay, you
Okay,
can
check
see
the
now.
image. Sure. Okay, start pull back. It's coming. It's a proximal circ.
Right at the ostium. Yes.
Yep. Okay, short pullback. That's it. Yeah, definitely bigger lumen.
You want to try?
Yeah, I will show
IVL
the.
can be done again
So this is
in
the
the
left main bifurcation.
LED or forget
No, I
it.
think
Actually,
we
area-wise, it's still
understand.
very obstructive lesion at the osteocirc, even after ROta and the IVL. And what else we can do?
I mean, angiographically, if you see that stent is, I mean, the balloon is dilated. This is only 3.5. I know the vessel is 4.0, right?
This is
I mean-
circumflex.
Yeah, this is the osteocirc.
I think we can just, we'll just stent, Kiski, agree?
Yeah, I agree. Because, if we can use the OCD, we can see more deep part of the calcium, like thickness of
Yes, we
small
get that.
fracture. IVUS-wise, it's sometimes hard to see, but you said angiographically expanded?
Yeah. See here. You can see it. Angiographically expanded. Let's try once more.
Okay.
Yeah. We are just again going to try into the LED if the IVL can go. I doubt it, but we'll try once more.
One more trial to the IVL to the LED will be an ideal. Then you do go for a two-stent strategy with that will be the ideal one. Actually, it's a short lesion, lengthwise it is very short.
Yeah, very short.
What was the left main? 4045.
Like 4.3 vessel. Maybe 4 is good enough.
Okay.
And very
Open
short, like
the
5 millimeter left main. Very short left main.
Very short left main, short lesions. Very interesting case.
But difficult.
Naturally.
Okay, IVL is not going. Let's open the stents now. 3518 into the circumflex, 4018 into the left main to LED. Again, various two-stent strategy techniques are there. Of course, we always say and have done and shown mini crush. So we can show the mini crush technique. Andrew, in the side.
No, Dr. Kinney, you require 18 millimeter to the circumflex or you require a shorter stent?
No, we can go with a shorter stent, but we have it already opened, so we just use it.
Okay.
Yeah.
418 to the length. Okay. You will be putting a 3.5 into 18 to circumflex and then crush it. Then.
Let us, this is my EYE IVUS. You understand? Eyeball IVUS. EYE IVUS. Let us ask the true IVUS guy. Now, the 18 I took long just because we had it. Okay. So if somebody says I'll just put a 12 acceptable, I'll put a 15 acceptable, 16 acceptable. But more important is left main to LED. We already are saying take a 4.0. So we'll do a 4.0 from left main to LED, and then we will do a proximal optimization with the 4.5. It's 4.3 is saying. We can go high pressure 4.0.
Sorry,
Take a 4.5 nominal pressure or a 4 in the high pressure?
No, I think high pressure is needed. We will go with the 4.0 high pressure.
So, can I talk a little bit again? So, sorry, about IVUS? Dr. Kinney, I will show you some
quick.
small hematoma. So, can you show the IVUS on the screen? So, this is the post IVL circ IVUS, and I missed a little bit. So, this is a hematoma opposite part of the calcified nodule. So, so
this is what we predicted.
Yeah.
What me and Amit have seen, having done so many ROta and IVL cases. This is an example. Okay, that after IVL we are seeing this kind of I said earlier contained perforation. This is like a hematoma, so non-calcified area. Though the most company people tell us this does not happen, ultrasound is very safe and all that. We have consistently been seeing this. In the 2 live cases, we have shown it also. Contained little perforation.
Now it's definitely good to go
definitely
stent.
big. So what he's trying to tell us,
atherectomy, so.
what he's trying to tell us is go low pressure. Is that what you're trying to warn us, Kiski?
Yeah.
So then we are going 4O,
18.
18 into the left main to LAD. Hold the wire, yeah. Oh, 4O. So we are going now. Is the mini crush playing in the side? Oh, wow. Forget it. We have a trouble here. What you want to do? Will be a
Maybe
decay
the
crush?
wires are I think wrapped around maybe.
No. This is a circ.
Yeah. So this is the LED.
Well, if the stent does not go, you can do a balloon crush and then come out and then take a stent down. That is also one
Yeah,
of
yeah,
the-
yeah, yeah. There will be a decay crush otherwise.
This is the circ.
Okay, this is a circ. Okay, you're right. Also, what happens is, despite it is 7 French, right? We have a 3540. We do sometimes
a-
see that, but we have had the problem here.
No, actually, you can take the stent. One technique is actually taking the stent down as then you can push. That is why. A circumflex stent can be taken back and then 4 millimeter stent into the lady, then take the stent again to the circumflex because circ
Okay,
is-
you know what? Let us just deploy this, crush it, and then go. Go, go.
Okay.
Leave
You
it
want to
there.
keep a balloon over there?
You want a balloon?
Yeah.
Okay.
Because stand. Or else you want to try, take the circ,
Okay, there
circ
is,
head and try the LED if it goes.
No,
I
no,
don't
there
know
are
unless
two-
there is a crush, because earlier the one important thing is that a wire wrap. So earlier I did recross into the LED once. Okay,
Balloon 3.5.
that was before we did balloon and all that. So they want a balloon in there. Okay, we are going with, ideally should be 4O, but they say we have a 3.5 balloon. Let's just go with the 3.5
Yeah,
balloon that
3.5
we
ready.
have, and we'll just crush
If
it.
the stent is not going, so she is going to do a balloon crush there, not the stent crush.
Now what we have called this technique is
Step.
modified crush, which is mini crush, where we are not going to recross kiss the step of the decay crush. We will just crush it and then place a stent. Well, what we see when we do something like that, then recross becomes really hard. See, there's some, you know what? Let me. No, there is no wire entanglement. You see that? Look at that wire of the LED. It's nice. It's coming back. Let us just place it. See that?
Yeah.
Something otherwise wrong.
So there is
Okay.
a way that you can actually take the balloon stent back into the catheter and take a balloon into the lady and then take the stent down. That is also a possibility.
You want us to do that again?
Yeah. Means that's a reasonable one.
Okay, let us see.
Maybe that helps.
I would have just placed it and done, but let's see. Everybody wants that way. Let's do it. I think this eccentric calcium is really not doing the job. Go up here.
Oh.
Other thing is, do you want to do a high pressure, like a cutting balloon? Go high,
19,
right?
20.
Good, down. You want to give a 4O? Get us a 4O 15 high pressure balloon. Or you think we have to do a cutting balloon? Go up here.
Distally and take the stent down.
20. 6.20.
Okay, they want this way. See, the one thing you could do is, remember we could not do IVL. Can we do a cutter there, high pressure, and come out and do our mini crush? Other one is, they're saying go down with this balloon, leave it there in the LED and try the circumflex. What do you want to do?
Yeah.
I think we can try the 4O stent again if everybody agrees. That will simplify the steps.
Okay.
Instead of just
Now, before
crushing
that,
the
we have to
balloon.
really dilate
No,
here.
I think the
Go up,
balloon
go up,
opened
go up.
really well.
Go, you went high pressure,
Yeah.
right? But it is
20
3.5
atmosphere
only.
this time. Yeah. But this 3.5.
Okay, down.
So it looks well
Okay, get us a 4O stent again. Is the stent okay? Remember we tried, we went forward, backward. Okay. So now,
Now you are going to take the stent into the LM to LED now. First,
Okay, we'll do that first. let's
What
do
is the-
let's do left main to LAD first, and then we go from left main to circumflex. Okay,
Okay.
let's do that. I mean, I think high pressure with 4O was probably needed, but let's see now if this goes.
The balloon expanded very well, actually, according to the osteoproximal part of the LAD was only 3.7 or 3.8 by the IVUS. So it is expanded very well.
I think because it's a 4O balloon, I mean 4O stent, we have trouble.
3.5. 7 French also is not enough.
You want to go 3.5 then? Get us a 3.5 stent. 18.
No. Already there is a stent of circumflex 3.5 into 18. I think she's planning for another stent into the LAD also 3.5.
If you have 3.5 4O, I think you need a 8 French.
Not stented.
Don't
Other
connect
options
yet.
actually, do a cutting balloon into the osteoproximal LAD and then open the vessel. Actually, IVL did not go, so you can take a cutting balloon and dilate. That's also one option.
Okay, now we are having trouble of everything.
Lot of interest. Then we'll just go to the
Oh, you know what? You know what?
What has happened there? There's
Nothing. It
four-
is just two stents are not going through in that. I think I have to
Right.
advance one of them into the vessel. Yeah, in the guide.
Okay, no problem.
This is a.
circumflex.
Oh,
Keep the balloon ready. 3.5.
see,
Yeah, otherwise
I would
we'll
have
just
just deployed that and be done with it. No,
I think
now by dilating, we might have created something else in the
then
left
we'll
main to
just
circumflex.
do the step 1. We can take out this stand and keep a balloon over there.
No, even now this is not going. See, I was ready to deploy the circumflex stent. Now we have everything is going backwards.
No, circ stent.
what is
Actually,
your
even now
plan,
you
madam,
can put
now?
a circ stent and keep a balloon into the LAD and then crush the stent with the balloon and then subsequently.
Yeah,
take
but
the
now
balloon.
we dilated the left main to LAD. Even the circ stent is not going into the circumflex. Give the balloon again.
Yeah, I'm ready with the balloon.
The biggest, I think, nightmare for interventional is nodules.
Not, madam, repeat it, please.
Nodule, calcific nodule.
Module, okay.
Yeah, nodule. That's what it is. We are struggling here now. What is this now?
It's 3.515 high pressure only.
Give me 4.
4. Okay.
Madam, do you consider orbital at this point of time?
No. I think ROta has done its job. We did ROta, everything we've seen. Yeah. ROta has done, IVL has done its job. We just need, what we have created is once there is nodule, we have created some fracture within that area. It just does not go.
Balloon,
4O,
we want
what?
balloon. Yeah,
Huh?
4.15. Yeah, that's okay.
There is a hematoma created, so orbital is absolutely contraindicated at this point of time. There is no doubt.
So next is IVL.
No, IVL is
not
actually, you
toxic.
can take a 3 millimeter IVL, you can take. There is actually another choice. A cutting balloon into the LAD osteoproximal part, you can take. There are options.
No, I would not do IVL. IVL where?
No, I'm
You
just
want,
telling you
if you want to do a cutting balloon to the LAD, agreeable. That's what, I mean, my choice would have been, but we all decided we'll go with high pressure balloon.
Also, now, no, discussion point of view, what are the other? Orbital cannot be done. That's what I told.
Now, once there's a hematoma, I don't think you should do anything else. Go up here. Get down. Right, go.
10
higher.
only.
No,
Yeah,
12,
it's
14.
4.
Okay. Okay. Give me that 3-5 stent. We are not going to try a mini crush. Let us place circ stent.
12. 14.
Hmm?
14 now.
Okay, good. Give me a new 3-5 balloon. Okay, the one that is used, we are not going to be using it. And 3-5 stent now.
Yeah.
Let us just quickly place the stent.
So what is plan is? Plan is to do the circ stent and then balloon crush and then later on LM to LAD stent, or what is your plan now?
Yeah, let us get stent into the circ first. You have the 3-5 ready, new one. Now, 12, high pressure. I need high pressure. This is a 3-5.
3-5,
This is the
18
same circ
stent.
stent that we have tried multiple times. Okay. Now it went.
Then the
You see
balloon.
that?
It's 4.
Okay, go. Connect.
3-5. Then yeah.
Connect.
I'll give you the pressure balloon also for the LED.
I don't think we should try to the LED, right?
No, we keep the balloon in the left main to LED just
Okay.
to crush it.
No, what I meant, should we try the left main stent again? Left main LED.
no, I think
Okay, everybody is
no.
against. Okay, let's go.
Left main LEDs tend to be not to be used. I think a balloon can be taken. I think stent again taking confusions.
Okay, fine. We are going with the balloon. But I am telling you, we could have been done with the case if we had deployed it first time. Yeah.
Yeah.
Will always tells me, do it your way. Okay, gun, connect. Ready?
Sorry, 1 second. Let's keep it. Keep the balloon.
Now it is gone.
Okay, good.
Yeah. Don't do anything.
Maybe you can actually just.
Okay,
crash
now,
and take
ready?
it.
Yeah.
Now the balloon is also there. Everything is there.
Okay, I'm going to pull back. Okay.
Yes. Ready.
It is actually which stent?
Okay, some die.
Which stent? It is Abbott stent or?
Yeah, this
Yeah.
is the Abbott stent.
This is Zion's 3-5.
Giants.
18.
Okay.
Okay, some die.
Oh, this is too much into the ostium.
Yes.
No.
Okay, now we are good. Good?
This is okay. Yeah.
Okay, so hold on. Can you hold it so you're ready to go up? Okay, give some die. Okay, go
I
up,
think this is
right?
good.
Yeah.
Go up. Stand. 14.
Enough, 14.
Yeah.
I know it is 4O vessel with
No,
the
this is
hematoma,
3-5
we are
only,
down. Yeah, down. Okay, go up again. Look, keep checking the hemodynamics, okay?
14 and down.
Okay, good,
That's it.
down. So now I remove this balloon and I'll remove the wire and now go up with the LED. I mean,
Crush.
Yeah.
left main.
Now
Now
crush.
you are going to
Going
crush, yes.
Yeah.
This is.
Down.
This just.
No, ideally would be 4O. We did not go with the 4O. This is 3-5. 3-5 high pressure balloon,
Going up.
regular balloon.
Okay.
How high?
20 and down.
22.
22 and down.
Okay, so now
Get that stand. 4-0. We have 4-0, 18 now.
let's take a picture.
Yeah.
Take a picture, all right?
Ready.
Wait. So far, so good, despite all this.
Yeah, good result.
Very good,
Okay.
very good. Now we will be putting a stent from LM to LAD and recross and then kiss. That is our plan.
Yeah, that's our plan.
I need a new fielder wire, okay? To recross. Now, once we place there, we have 4-0. What are we going?
4-0, 18
Okay.
stand we had.
4-0, 18. Is this 4-0, 18?
Yeah.
We go with 4-0, 18. Okay. So we go with 4-0, 18. We pot, then we recross. Okay?
Yeah.
No,
you
what is
replace
this? No, the stent.
Stent, brother.
Stent. Make sure it's 4018. Now we opened two different kind. Yeah?
Just keep the relevant thing. Keep other things in the back.
Madam, can you replay the video after the
App?
stenting of circum?
Sure.
Replay what? App?
No, the image, I think.
You want the image?
Yeah.
Image, yes.
It's
Osteum is covered. Yeah.
This one?
Yeah.
Yeah, it's fine.
No, there was
Yeah.
We had a small doubt whether the osteum was missed. It's well covered.
Okay. Happy? Good. Now we hope this 4-0 will go, okay? Have the 3-5 ready. Oh man.
Ready.
Okay.
Yeah. Vent.
Now we have to apply brakes. We say we apply brakes. Flying. Okay. Now we want to make sure we are covering the ostium.
Cranial.
Some dye, and then I have to go cranial, right? So if you want to make sure the ostium is covered, I mean, we don't want true ostium. True ostium was not involved, right, Kiski?
Yeah, yep.
Huh?
Which
Okay.
is the best view, angiographic view, to see whether the LM osteum is covered? Eleocranial?
2020.
Aleocranial, epicranial, RAO-cranial, depending on the patient body habitus, some dye. You see here, it's looking good. So I'm going to come back a little bit, not a lot, because if true ostium and you're sticking out, there's a risk of LSD. Okay. Everybody agrees we are good? It's not true ostium. Huh?
Come
I
back.
think we are good.
Come back.
Okay. I came back. I'm not going to the true ostium
Okay.
because the guide will destroy the stent. Yeah, go up.
Okay, going up.
Kiski, can you IVUS? You didn't answer me.
No, it's balloon ruptured.
Down.
Yeah.
I knew that.
Ostium
Now
is
it's
not
trouble.
basic problem
Yeah,
is
no,
actually it's a 5 millimeter.
Ruptured, balloon ruptured.
Okay, give me 3-5 or 4-0.
Give 3-5.
Get us a
Give
4-0.
3-5.
Okay, give the 3-5.
We'll
Let's
utilize
open.
that one.
Remember I said we went multiple times.
Yeah.
That was a risk.
MC osteum. If you have enough space in them, then it's okay. Otherwise,
4018.
Yeah. We have 3-5. We'll use 3-5.
Give me.
We are on the table.
Okay.
Yeah, let's go
Okay.
there.
So remember I kept asking the questions to my fellows here that is the stent okay? You see that we went there, we went up, we did not see it going up, which means there was some probably either the tube has a problem or something. Luckily it came out quickly, so we're just going with the 3-5 stent that we had, okay? Okay, go up. We are
I'm
losing
going to
time.
take a 3.5 stent now, right?
Yeah, I mean, we had it open, so we're just using it. Okay, so now die. Okay, go up.
Yeah, going up. Yes, I am at 14, 16 now.
Okay. Down. Get us a 408 millimeters, 408 balloon for optimization. So now to make optimization, we will go back in the caudal view, okay? And then we'll recross, then kiss, then IVUS. Good.
This 4-0. Okay.
We'll take a picture now
Yeah, ready.
to show everybody how things are. Okay, beautiful.
Nice.
Okay, give me 408.
Yeah.
Now, ideally, left main to circ, right? When we want to kiss, recross, I would go with high pressure balloon. But now we have struggled so much in this case. I will go with a smaller balloon, create a lumen, and then go with a high pressure balloon.
So reset.
Okay, come. So, it's not even we will be across, you see that? Go up.
14 atmosphere now. 16.
Down. 4-0?
Yeah, this is 4.
You may have to go 18 now.
We'll come back.
Okay, go up.
Yeah, going here. 20.
Okay. This is the proximal optimization down, very important, and we show that in the app. The app is going in the side, right? the steps wise. Go up again here because
Here I'll go
we did
gentle.
not do mini crush. You have to
Yeah.
crush it now.
10,
Good.
12 only.
Yeah, enough. Down. Now get me the fielder and let us recross here. Everybody is following the steps. I think get me a 3, 5, 15 into the. No, into the main vessel we have the same balloon for the side branch.
2 or 12. Get 2
No,
or
3,
12.
5, 12, right? No, no. Oh,
Later
regular.
on,
Okay,
yes.
okay. Yeah, recross first.
Recross first.
Recross with 2, 5, 12, then we go with high pressure.
Yep.
So now recrossing the side branch, we always like fielder. Some people like whisper here, but I like fielder, polymer jacketed, hydrophilic wire. There will be again a discussion around that. Right? What is the wire choice for the side branch? Any questions from the audience there?
Crossing, do you prefer any distal, proximal, mid, non-distal?
How will you do that if you can tell me?
I don't know.
Yeah,
Yes.
so what I'm saying is if we can get a simple, we call this as an optimal cell, that if the wire goes, that's what we go with. If you need to understand proximal, distal, you have to do multiple imaging.
Yes, of course, but what's the guidelines?
There are no guidelines for which cell to cross. Okay, now we went through. Now if the balloon had not crossed, then we will have to get a hold of. What happened to the pressure here? Okay. Yeah, fine. Go, go, go.
Get that 3, 5 ready now. 16, 18.
Okay, down. 3, 5, 12, high pressure. Yeah. And the 4O is there, right? We can use the same 4O.
3 or 4.
It's not based on any randomized data or outcomes saying which cell to be crossed.
This is what?
So it applies to all the bifurcations
3-5.
as per your.
Yeah, all bifurcations, left main and non-left main. But we never follow it here. And in every live case, we always say that as long as you're able to cross optimal cell. This is 3, 5, 12.
Yeah, 3, 5.
I think you got to give a new one.
Panel agree? To the panel agree that crossing of distal,
Non-distal
non-distal
cross
also
this idea.
matters.
Madam,
does
can we
matter.
go to the other lab because other lab person is waiting for the last how many minutes? 20 minutes. We just see the crossing and then we will go to the other lab and then we'll come back for the seeing the final result.
Okay. Go.
No, no, that lab will be too much. We'll be done.
18, 20.
Right? Okay, done. No, no. Get me the other 4O. We'll show you the IVUS and that's it. Give me the IVUS.
4O.
Oh, 4O. Oh, no, no, no. You're right. 4O, 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 4O.
4O.
Let's finish the kissing and quick IVUS. We said we had 1 hour. Oh, we're done almost. We were thinking a lot of discussion, but what we can do is we'll do the final kiss and then you can go. Or you means you want to go now? That's fine.
Yeah, and they
right?
want to come back. Yeah,
No,
I
we
think
have
that's a
no.
good
Okay, we can
strategy.
show later. If you can come back, we can show you the IVUS. Case could be done, right?
Yeah.
Okay, good. If you can show the angiogram. Huh? So this was our final angiogram. I think we left when we were doing the kissing balloon, right? So this was the kissing balloon. Then this is the final angiogram. And then here we are. So quickly, we are going to show you the IVUS. We did the IVUS from left main to LAD and left main to circumflex.
Okay, so this is a pullback from the LAD to left main. So this is the distal edge of the stent on the calcified plaque, but no malapposition, no dissection. Now come to the proximal edge, well expanded. Then this is the bifurcation, left main bifurcation, like no clear metal mass, so it's a well crushed. And the proximal edge of the stent is at the just at the ostial left main. Now we go to the second pullback. This is the final pullback from the circ to the left main. And again, the distal edge is on the plaque, but no malapposition, no dissection. And most are concerned, ostial circ is like eccentric shape, but area is like 7.4 well expanded. And again, the left main is good. And the previous hematoma is covered by the stent. So IVUS was it's perfect from the LAD and the circ.
So our goal was just at the ostium. So our EYE IVUS confirmed, and we were able to place that we nailed the ostium. You see that we don't have the, if you're trying to cover the ostium, you want a 1 or 2 strut just outside sticking, but we knew that that's not what we are going to do. So there was a concern also if the ostial circumflex stent actually covered the ostium. So in the IVUS we can confirm in both time that even in the LAD pullback and the ostial circumflex pullback, you see that the ostial circ is covering the ostium. And we know the Achilles heel of bifurcation is always the ostial circumflex. And that's what I think we are going back to the point that you got to do a good calcium modification of the ostium. So we did rotational atherectomy as well as IVL, and this is where we are. Our MSA is above 7.
Yeah, 7.4. Yeah.
Yeah. So that's where we are with this. Any other questions regarding this case before we finish?
Madam, our final result is very good, and we appreciate it. And only one question, and where do you place orbital atherectomy in your practice?
Sorry, can you repeat it? What atherectomy?
What is your indication for orbital atherectomy in your practice?
Oh,
Orbital.
yeah. It's a very difficult question to answer because I think we have explained which cases and all that. So orbital atherectomy, like we say, rotational atherectomy requires a little bit of training. It may take a longer time to explain, but in short, right? In the rotational atherectomy, you see that it's conical in shape and diamond chips are in the tip of the burr. So if you are doing uncrossable lesion, so where you cross the CTO, you're in the lumen, nothing is going, you want to do something, that is when rotational atherectomy will come into existence. In this case, we have had a lot of discussion. Could OA be done? Could RA be done? Both could have been done. The biggest reason why rotational atherectomy is preferred here in Mount Sinai, of course, Dr. Sharma was a pioneer who started it in the beginning, but more important reason is the physics principle of deflection. This was discussed again. There was only 2 quadrants of calcium, then there was normal vessel. So the physics principle works really well when you're doing rotational atherectomy. So you have calcified area that will be the calcium. The rotational atherectomy will do modification, but where there's no calcium, it deflects it. And that is what we saw here. It deflects it. Now going back to the point, how does orbital atherectomy? It orbits, it goes round and round. And we saw in the earlier part of our practice that, like we saw in the IVL here, we were seeing hematoma, little cuts and dissection, which we have already published when we use orbital atherectomy. Now your point is, where can we use it? So though people say it, so if you really would think where it can use it, that in mid LAD, mid RCA, okay, real distal lesions, because rotational atherectomy, it's only 9 millimeters. If you think you want to go real distal, like a distal RCA PDA, you got to do dynaglide and take ROta all the way down. And we think you cannot do that. Orbital atherectomy is a okay situation where it can be done. Then very rarely people do say, but we do not say, ostial lesions. So if you have calcified ostial lesion, ideally what works is rotational atherectomy. Why? Same. If you see it is eccentric, your the diamond chips are eccentric in the orbital atherectomy, but here it is conical. So if you're doing ostial, rotational atherectomy probably is better. So where can it be used? Not in my practice, but I'm saying in general that if you're doing a mid RCA, mid LAD, this kind of situation, or distal lesions, yes, orbital atherectomy can be used.
Thank you very much, madam. Thank you for nice presentation. Thank you very much.
We can show the final slide of the app. I know there are a lot of, young attendings and fellows. So this is myself, Dr. Sharma's goal is teach the universe how to do complex procedures, and this is our educational applications that we have. It is free. You can go to our cardiologyapps.com. We already have 14 that has been released. Whatever we have discussed here today is available there in the apps. So bifurcate, and more important, calcificate, when to use what calcium modification is there. And I know before our session started, there was a discussion on management of complication. So if you go to the Complicate website, you can learn a lot of that. Lot of cases are there, about 80 cases, all complications of the cath lab, that how to manage and how to avoid, keys how to avoid can be seen there. Again, we would like to thank you. Bye-bye.
Thank you for the wonderful case. Okay, thank you.